Nick Majerison here. Welcome to Top Med Talk. Now, before we get cracking, Top Med Talk is going to be at the International Fluid Academy Day on November the 23rd in Amsterdam. Full details, topmedtalk.com. Click on the section marked Events. You'll be able to find out more. It's on November the 23rd. It's in Amsterdam. It's the International Fluid Academy Day. Going to tell you more about that towards the end of the podcast. In the meantime, it's time for today's Top Med Talk. Smoking kills more than all addictive substances combined, plus car accidents. Part 1 of 3. And it's presented by James Davis, Director of the Duke Smoking Cessation Programme. It's about standing up a preoperative smoking cessation programme at the institution where you work. The rationalization, data, outcomes, economics, all of the detail. It's a 3-part series, and this is part 1, taken from the hugely successful EBPOM-USA Masters course, Perioperative Care Practicum, which took place in Atlanta earlier this year. Have a listen. I'll give you some words at the end.
Top Med Talk.
At any one time, when we ask a smoker if they would like to quit, 70% will say, yes, I would like to quit. This is kind of interesting. And most smokers that we talk to say that they've tried to quit on average 7 times. And here's the paradigm shift. And it's not listed in these figures. The paradigm shift is that in that 15%, this 15% looks really different from that 42% or 50% that it was. This is a highly comorbid population. It's a population that has psychiatric illness, that has low education, and it's a population that is very difficult to treat. And their success rates when they try to quit on their own are under 5%. And what that means, and this is the paradigm shift, what that means is that for many, many years we've thought about smokers as a population who just need to learn that smoking is bad for them and make a go of it. You know, do your best and quit. You know, you just need some encouragement. This is not actually a relevant understanding for smokers today. Smokers today, when they try to quit, are not able to quit, and they need a lot of help to do it. So that's the paradigm shift. And here's the population. If I look at my colleagues and buddies, we've got about 5% who smoke. They're probably less among physicians. If we go up to people who haven't gotten through a graduation for high school and they got their GED, it's at 43%. I mean, that's a real difference. And essentially with education, there's a dose relationship between education and an inverse dose relationship between education and smoking. Income status looks very much the same way, and with poverty level below and above the poverty level, it's almost double the rate of smoking when you get below the poverty level. And the other big predictor is mental health conditions, where we have 40% of men and 34% of women who have mental health conditions smoking. And about almost a third of all cigarettes smoked in the U.S. are smoked by people with mental health conditions. They smoke at higher levels. They smoke more cigarettes. What this means, just in terms of, as I'm approaching the smoking population, is that these are people who oftentimes have low health literacy. They may have superstitions, and I should tell you a funny story about just this week, but they may have superstitions. They're often very poor, they have limited resources, and they're also often smoking as a part of psychiatric comorbidity. This last Friday I had clinic. It was Friday the 13th, and nobody showed up. I typically have, in a 4-hour period, I typically see 8 to 10 patients, 8 to 10 smokers, and nobody showed up, and I couldn't figure it out. We had one patient show up on Friday, and I couldn't figure out what was going on. I looked around at the entire clinic. This is a clinic for disadvantaged people. The clinic was bare, and I asked the social worker next to me, what's going on? She's like, oh, it's Friday the 13th. No one ever comes to the doctor in this clinic on Friday the 13th. And I realized this is really a low SES population. These are people who believe in Friday the 13th. I just thought it was a joke. So here are the impacts of smoking on society. And this data has grown and become more nuanced over time. We always knew that smoking caused death. Now we know that approximately 2/3 of smokers will actually die from an illness caused by their smoking. And this has to do, these are analyses that co-vary out the incidence of heart disease and stroke and cancer that would occur without smoking. This is over 500,000 deaths a year in the U.S. The hard part that was recently kind of put into this was heart disease, which is about 1/3. Heart disease, and this is something that most patients don't know, heart disease is the major reason that smoking causes death. That's the major, it's not lung cancer or COPD. Followed by heart disease is lung cancer, then we have COPD, then other cancers, stroke, and other diagnoses. But a lot of, this continues to be the number one preventable cause of morbidity and mortality in the U.S. Smoking kills more people than all other addictive substances plus car accidents. It's very impressive. Here's some other just kind of facts and just interesting things to know about it. This is the Surgeon General's report that another one came out in 2014. So smoking is a cause of COPD, and I'm actually using the word cause here. Cause is a funny term. I stay away from it in randomized controlled trials, and I run studies, and we just don't use that word. This is a consensus statement when we have population data and pathophysiologic data and randomized trial data, and it's all showing the same thing. Then people in a committee will say, you know what, I think smoking causes lung cancer. I think we can say that now. I think there's sufficient evidence. So we now see smoking as a cause of COPD, asthma exacerbation, pneumonia recurrence, cardiovascular events, and let's just talk about that for a second, because with everything up here, there's essentially a dose response. The number of pack years, that's the number of packs per day times the years you've been smoking, are very closely related to the incidence of lung cancer, to vascular burden, that's plaque burden. We'll talk about diabetes, cataracts, but it's not related to cardiovascular. Cardiovascular events essentially have a stepwise, it looked like a step function. And we think that it may be, there's not great evidence for this, but we think that it may have to do with inflammation. Smoking causes platelets to aggregate more easily and then stay aggregated more easily. And we think that may be kind of a part of this. But it means that you can smoke a few cigarettes that's a day, and it still leads to enough inflammation to cause these events. Now, and so we want to get people all the way down. With respect to cardiovascular events, and stroke is the same way. We want people to get all the way down to nothing in order to reduce that. Diabetes, just to mention that, there's a 30% increased incidence of diabetes in smoking. When I talk to my patients, and I would encourage this with any clinicians here, I say toxins from the smoke enter your lungs, they go into the bloodstream, and they essentially bathe every organ of the body. Smokers think that smoking goes to their lungs, and that's what it affects. And I think that it requires a little retraining for many smokers. So we believe that these kind of inflammatory mediators are shifting people who have a slightly lower hemoglobin A1C into a slightly higher hemoglobin A1C. We certainly see that smokers have those higher hemoglobin A1Cs, and that leads to a shift in the number who meet the criteria for a diagnosis of diabetes. Cataracts and then obstetrics changes. There's a huge list, and I just wanted to bring up some of them. These are cancers that are caused by smoking. We all know about lung cancer, bladder cancer, but many of my patients don't know about breast cancer, cervical cancer, rectal cancer, leukemia, gastric, pancreatic. I mean, essentially, the list is quite long, and my guess is in a few years it'll be longer. So this is just kind of what we discovered. This is my own compilation of studies. So what about smoking and perioperative outcomes? I would say at this point the case is quite strong that smokers do worse in many domains than non-smokers. This is a trial. I forget. This is a meta-analysis looking at lots of trials, and I think it was 25 trials on this one, 22 or 25, nearly 3,000 patients, and comparing smokers to non-smokers, and we have in the perioperative in the postoperative period. And so we have septic shock. We see an odds ratio of 1.4, sepsis 1.38, bleeding and transfusions crosses the confidence interval line of 1. Cardiac arrest, we see stroke, ventilated time, unplanned intubation, pneumonia. 30-day mortality is up 30%, and any major morbidity, so altogether, looks like about 50%. So I think that there's a very strong case now that non-smokers do better than smokers in terms of their operative outcomes. This is another study. This kind of looked at 95 different studies, and there were about 12 that fell in, that gave this information. I'm not going to go through all the numbers, but this is from 2016. It looks very similar to the 2011 numbers. Now, the other question, which I think is really relevant, is if we ask people to quit smoking before surgery, does that actually make a difference? And I think the data now is starting to emerge that is fairly strong there as well. This was a meta-analysis of 9 randomized trials on quitting smoking before surgery, and looking at all postoperative complications. There was a 22% drop, and that included pulmonary complications and wound healings. Some of these studies had very short periods of quitting before surgery, and some were over 8 weeks. One of the findings with this meta-analysis is that if you quit for a longer period before the surgery, then that really makes a difference. So again, I think that the evidence is growing, and it seems to be more and more consistent that quitting smoking before surgery is really beneficial. And that gets us to a more complicated question. When do we actually quit before surgery? And I think actually that we need more data on this. I was not that thrilled with the level of data that is out there. And perhaps we can generate some of it at Duke. Here's some things that happen when a person quits smoking. Very quickly, their carbon monoxide levels fall. That's going to happen in the first couple of days, but continue in the first week. Tissue perfusion increases. That happens rather dramatically over the first couple of weeks. Nicotine withdrawal occurs, and so when a person smokes, they have upregulation of nicotinic receptors. When nicotine binds to a nicotinic receptor, that releases serotonin, norepinephrine, and dopamine. And then when a person stops smoking, all of the levels of those 3 neurotransmitters drop. And that is the experience of withdrawal. It is low dopamine levels, low serotonin levels, low epinephrine levels, and it's a tough batch of neurotransmitters to have gone, and people experience some real distress in relationship to that. The worst of it for most smokers is about 1 week, but it doesn't really resolve until 2 weeks. And people who are heavy smokers who've gone a long time, you'll see withdrawal symptoms go out to about 3 weeks. Now, this is starting to tell me a story when I'm thinking about how soon would I like to have somebody quit before surgery, because I think that it would be challenging to go through a surgery and be in the middle of withdrawal. I think that would be tough. So it would be nice. It would be nice in my mind, and I'm saying nice because this is not the physiologic data. It would be nice to have surgery after that withdrawal period. I would say for most people that would be after 2 weeks, and for some people after 3 weeks. We know also that when a person first quits smoking, the ciliary hairs start to come back online, and we see secretions start. And we'll see it sometimes 24 hours later, sometimes 48 hours later. That will start, and there's a lot of coughing, and they're coughing up a lot of junk. And that's not good if they're under sedation, if they're on opiates after surgery. We don't want people kind of having lots of secretions to deal with when they're also dealing with an operation. Those secretions are really bad in the first week. They tend to fall off in the next week or so. Also, and I just listed a little bit of this, but there are a lot of immune function changes Natural kill cell function improves, cortisol level decreases, platelet clotting function, platelet clotting, that's the heightened clotting that we see in smokers. That decreases, and that all happen. Different things happen at different periods, but that all happens in the first 1 to 4 weeks. The other thing that we know is that after a person quits smoking, their pulmonary function increases it usually takes 2 or 3 weeks for their pulmonary function to kind of, there's an inflammatory component to that, and as the inflammation resolves, you see a little change in their spirometry. But then we see a gradual increase that goes out to about 6 months after that. So this is just kind of something to keep in mind. If I could have somebody quit for 4 months before surgery, fantastic. The longer, the better. And the question is more, a practical question is that for many surgeries, we're only able to see people for a brief period of time, with a relatively short period of time before the surgery actually occurs. So what about data on outcomes? And here I think, again, I wish that there was better data on this. This is the best meta-analysis I could find. And what this showed was that if folks quit, this is respiratory complications, and I should say the reason that we're looking at respiratory complications is that that's the thing that that's the area where we're most concerned about side effects continuing on for a period of time, and we want to get through this we want to have lungs recover as much as possible before surgery, and they seem to take the longest, and they seem to show continued change over time. So that's why this study is looking at respiratory complications, because that's the lagging piece. That's kind of the rate-determining issue for most of these. Other things like wound healing, they pop up more quickly. They rebound more quickly. If folks quit, if a smoker quits within 2 weeks of surgery, there's actually an increased incidence of respiratory complications. Now, I want to be clear, that's a relative risk of 1.2, and the confidence interval crosses 1, which means that is not a statistically significant finding. It does fit a story, and I tend to believe it because it does fit a story, but I'm not that impressed with this data. If you go out to 2 to 4 weeks before surgery, respiratory complications, the incidence comes down to a 14% increase, 1.14. Again, this is crossing. It's kind of moving in the right direction. I tend to believe it, but it's not statistically significant. It would be nice if we had better data than this. And this is respiratory complications. I want to be clear because in surgeries where we're not that concerned about lung function, if we're not going to have people on the ventilator, I don't think this is as much of an issue. But once we're out at 4 to 8 weeks, then we do have statistically significant findings, and there is a reduction of about 23% in terms of respiratory complications. Once we're out over 8 weeks, it's about a 50% reduction. And that is, both of those are statistically significant. My take-home take-home way of thinking about this is, 1, we need better data. 2, if I want to be really sure that I'm going to get reduction in respiratory complications, I would like to wait 4 weeks. And 3, this applies to respiratory complications, not all complications. We see other things changing more rapidly. Like I said, this is kind of the lag. This is kind of the rate-determining change. This is the lagging. Wound healing over 4 weeks before surgery. This is the only. This particular analysis didn't look at under 4 weeks, unfortunately. So, and that gave us again significant change, significant improvement. So for most people, I would love to see a month. I'd love to see them quit a month before surgery, and then this kind of gets into practical issues.
TopMed Talk.
As I mentioned earlier, that is taken from the hugely successful EBPOM-USA Master's Course, a Perioperative Care Practicum. I mentioned at the beginning of the podcast we're going to be covering the International Fluid Academy Day on November the 23rd in Amsterdam. Now, this is a great opportunity for you to meet the team if you want to come along. All you need to do is check out the website, topmedtalk.com, click through to events, and you'll find a full piece on the website detailing everything you need to know about the International Fluid Academy Day, November the 23rd. Now, we've set up a Slido account for people who want to interact with us and our guests during the International Fluid Academy Day. Here's how you get to that. Go to slido.com. I've got a login for you. It's hashtag TMTIFAD 18. So IFAD, International Fluid Day 18, and TMT, of course, standing for Top Med Talk. So that password, once again, slido.com, hashtag TMT IFAD 18. So TMT IFAD 18 is an easy way of remembering that. That's live from the Monday on the 19th. You can get onto there, put your question in early and have a chance of having it answered sooner rather than later. Don't forget that login, TMT IFAD 18. That's hashtag TMT IFAD 18, and that's on slido.com. And then, of course, if you think you can come along to the day itself, that'd be great. We'd love to see you. Amsterdam, November the 23rd. Go to the website, topmedtalk.com, and click on the section marked Events. Also, of course, you can download our full back catalogue at the moment here on Top Med Talk. All you need to do is go to your podcatcher and click Download All, or scroll through them individually and clicking Download on each one, or go to the website, topmedtalk.com, and explore our back catalogue, downloading as many as you can. It's entirely free. You can get all of the back catalogue at the moment. We're currently sorting through it, so it may not always be available in that form. So get yourself to the website, topmedtalk.com, and download all of our podcasts, our entire archive, whole back catalogue, many hundreds of valuable podcasts with incredible information within.